And welcome to the Dr. Bob Show. What if you were hanging around with a group of friends and all of a sudden somebody started getting slurred speech? Their face seemed to droop to one side. They developed weakness of a hand or numbness or the same thing in the leg on one side of the body. And somebody in the room said, I think they're having a stroke. What would you do? Would you know how to handle that? Would you know the importance of making a diagnosis and starting treatment? We'll be spending most of this show answering those questions. My guest is Dr. Brian Wiseman. Dr. Wiseman is a board-certified neurologist, and he is the medical director of the Stroke Center at the University of Tennessee Medical Center. He'll be answering our questions. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about upper GI sudden bleeding, and we'll be talking about a painful big toe. Could it be gout? What is gout? What is the treatment? And what can you do for it? A lot of information for you. You'll want to stay tuned. We're talking with Dr. Brian Wiseman, medical director of the Stroke Center at the University of Tennessee Medical Center. We're going to be talking about strokes. Brian, welcome to the Dr. Bob Show.
Thanks for having me.
First of all, what is a stroke?
A stroke is a sudden disruption of blood flow to the brain, either a blocked artery to part of the brain, or maybe a ruptured blood vessel and bleeding in or around the brain, and that causes sudden neurological deficits in someone.
Which is the most common, the ischemic stroke or the hemorrhagic, the one where it bleeds or the one where there's blood clot?
The ischemic stroke is much more common. Probably about 85% of stroke patients will have an ischemic stroke, which means that there's a blocked artery and loss of blood to that part of the brain.
When that happens to the brain, then what happens to the body?
Well, it depends on what part of the brain is affected. And usually you think of left side of the brain affects right side of the body and vice versa. So if you have a stroke on the left side of your brain, you're likely to have weakness or numbness on the right side of your body. Facial weakness on one side typically. And there's other cognitive type symptoms that people can have, such as speech difficulty. Difficulty getting their words out or understanding. That's oftentimes a left brain problem.
When somebody has a ischemic stroke, what are the important parts of recognizing the symptoms early? That's really the message I want to get through here today. Is it important, or is it important not to do anything and be sure the patient's quiet and not get anything done, which is...
I think the most important thing that we know is time. When you recognition of the symptoms and deficits, and then time. The acronym we like to use and teach, it's a national push to use FAST. FAST stands for face, arm, speech, time. So you look at someone's face, you have them smile, and if one side of their face droops, usually the corner of the mouth doesn't come up, that's a point. You have them hold their arms up. If one arm drifts down a little bit, that's another point. And then you have them say something like, you can't teach an old dog new tricks. And if it's slurred or you can't understand it, that's another point. If you have 1 point on that scale, it's about a 72% chance of that being a stroke. If you have all 3 points, it's about 85%.
So if we were hanging out with a bunch of friends and somebody started having problems with their face drooping to one side, weakness on one side, and somebody mentioned the word stroke, what do you do? What should we do?
Well, the last letter of FAST is time. So T is time. Dial 911 immediately. That's the most important thing that you can do. Recognize and then dial 911 and tell the operator, I think this person's having a stroke. If you initiate that language of stroke, they'll know exactly what to tell the paramedics, When they arrive, they'll know exactly what to do with the patient in terms of evaluation and transport to a hospital.
So with a stroke, with an ischemic stroke, and you're not getting any blood to a certain part of the brain, how long before that brain loses its ability to think? When time is important, how quick is the time?
It's very quick, and some studies have shown us that if there's a blocked artery in the brain, one of the main arteries to part of the brain that's blocked, you lose about 2 million nerve cells per minute that blockage is not removed. And so there's variable factors in terms of the blockage and how much blood circulation you have in your brain. Everybody's a little bit different, but in general, if that artery is not opened up, you're losing brain cells by the minute.
So we have to get to the emergency room quickly so we can remove that clot. Now, you mentioned it could be to a bleeding into the brain. How do you differentiate? If it's bleeding, you don't want to give something to make people bleed more, but if it's an ischemic clot, you want to be sure and how do you tell the difference?
The main way we tell the difference between whether it's ischemic or hemorrhagic is to do a CT scan of the head. It's an X-ray of the brain, and we can tell immediately on that scan whether there's bleeding in the brain or around the brain, or whether there's no bleeding in the brain. So that tells us immediately.
Is that with just a simple X-ray of the head, or is that with a CT scan? Or that X-ray has to be done quickly.
It's a CT of the head, and that's the #1 test that we do right when someone enters the emergency department.
What do you look for?
We look for blood. We look to make sure that there's no bleeding in the brain, and if there's not, then that tells us if the deficits are correct, this is probably a stroke, and an ischemic stroke, and we need to treat it as such quickly.
So if the person had symptoms, they got to the emergency room in 38 minutes, and you made the diagnosis after the CT, and now it's 42 minutes, what do you do?
We immediately treat them with TPA as long as they're a candidate to receive that type of medication.
Now, what is TPA?
TPA is it's a clot dissolving medication, essentially. If there's a clot inside one of the arteries to the brain, it'll try to help dissolve that clot and reopen in that blood vessel. And that's our main goal and our main aim is if there's a clot in the blood vessel, to get it open as quickly as possible.
You give the TPA by mouth or by a shot or by intravenous?
It's an intravenous infusion. We give, over a minute, we give what's called a bolus of the medication, and then over the next hour, we give the rest of the infusion.
So how quick does the TPA work? How do you know if you're successful? How do you know if things are going to probably be pretty good?
That's variable depending on the patient. It's very difficult to determine the improvement after someone is given TPA. In the studies that were done, actually the improvement after TPA was seen 3 months after the stroke itself. So that improvement, sometimes we see a very robust improvement right after we give the medication. That's very nice to see, but it doesn't happen very often. If we see someone that has a blood clot in one of the large blood vessels of the brain, then oftentimes, the majority of those patients, we take for another procedure to try to get that clot out of that artery to reopen the blood vessel.
What do you call that other procedure? This is after you've given the TPA.
This is after we've given the TPA.
And there's a big clot, the patient's still having trouble. What's the name of that procedure?
It's called mechanical thrombectomy.
Mechanical thrombectomy, is that new?
It's been out for several years, probably just over a decade or so. Some of the first devices were starting to come out with to pull clots out of the blood vessels of the brain. In the last few years, there's been several studies that have shown very promising results at removing those clots pretty safely, actually, with pretty good functional outcomes for patients.
So how is that done? Mechanical thrombectomy. Thrombectomy means cutting it out, taking it out. How is it done?
It's a catheter-based treatment. So the doctor would stick a catheter in the large blood vessel in the leg, thread it up all the way into the brain.
Wow.
And then they kind of deploy this stent device, and the stent device grabs the clot, and then they can pull it out. Sometimes they pull it out with a little suction too to get all the clot out.
How often is that done? And let's just say at the University of Tennessee Medical Center in the last 12 months, how many have probably been done mechanical thrombectomies?
I'd say we've done probably on the order of 50 to 60.
Wow. What results do you see?
We see very promising results. A lot of the trials have shown anywhere from 50 to 60% chance of a good functional recovery after this procedure, and our results are fairly similar to the published trials, actually.
I think that's absolutely amazing. Are there other things that could confuse you with the stroke, like what is a TIA, and what if somebody has hit their head and they just don't feel good? Can you have other diagnoses?
Absolutely, yeah.
And that's what we're going to be talking about when we come back. The other things in the differential diagnosis, and we've talked now about the ischemic stroke. We haven't talked about treatment for the hemorrhagic stroke. We'll talk about a TIA, whatever that is, but we're going to learn. So you'll want to stay tuned. We're talking with Dr. Brian Wiseman, board-certified neurologist, medical director of the Stroke Center at the University of Tennessee Medical Center. We've talked about two different types of strokes. One, an ischemic stroke. That's where a blood vessel in the brain is blocked by a clot and there's no blood after that blood vessel. The brain doesn't get the blood that it needs for nourishment, and we get symptoms. The other is a hemorrhagic stroke, and that's a stroke where there's a bleeding into a blood vessel. The important thing is recognizing a stroke early. If we recognize it early, we immediately get to the emergency room. Time is brain function, so the quicker we get to the emergency room, the greater the chance for healing. There's a medicine called TPA, IV medicine, dissolves the clot. And then there's a mechanical thrombectomy, where with a cath we go up into the brain and can pull out that clot. Is that a pretty good summary so far?
That's an excellent summary.
Now tell me about a TIA. What's a TIA?
TIA stands for transient ischemic attack. Essentially, it is basically a stroke deficit that happens and then goes away.
Why does it go away?
The blood flow is restored in the brain, so you can think of it as a little clot that lodged in a blood vessel that dissolved itself. The blood vessel opens up, starts feeding the brain, and the function comes back. Traditionally, a TIA lasts less than 24 hours. More recently, we think of TIAs as something that happens transiently but doesn't leave a permanent mark in the brain on the MRI test.
Can people have recurrent TIAs?
They can, absolutely.
If they have, is that one a month or one a year, or they get them 3 a week? What's recurrent?
Well, it differs in different people. I think one thing that's important is if you're having recurrent TIAs, if you have one day and the 2 days later you have another one, and the next day another one, the sequence of TIAs I think is important, because what it essentially means is you could have a stroke very, very soon after a TIA happens.
Increased incidence of having the big stroke after people have TIAs.
Exactly.
What are the symptoms of a TIA?
Symptoms of a TIA are identical to the symptoms you would have for stroke. The only difference is it's transient. It doesn't stay there. It goes away, usually within 15 minutes, an hour and a half, 2 hours.
So somebody may have signs of a stroke. It's recognized, 911, they get to the emergency room, the stroke's gone.
Exactly.
And that's a TIA.
That's a TIA, and I treat it very similar to someone that's having a stroke. So in terms of the evaluation and to determine why they had that TIA or why they had that stroke, that's very important to help reduce the chances of an actual stroke happening after a TIA.
So there are things that we can do to prevent having a subsequent stroke.
There are things that we can do to reduce our risk of having subsequent strokes. Treating your blood pressure, making sure that's well controlled.
Why does the blood pressure cause stroke? Is it because, tell me.
Atherosclerotic disease, so plaque buildup inside the blood vessels, hardening of the blood vessels that create this plaque formation. and the small blood vessels don't like that, and they'll fill up with plaque and eventually occlude completely.
And it's the blood pressure when it's high that makes those plaques break loose and cause problems with us?
Exactly, and sometimes high blood pressure will cause little tiny blood vessels to rupture and bleed inside the brain. So we see bleeding type strokes or hemorrhagic strokes related to high blood pressure.
We so commonly see people that say, well, my blood pressure is a little high, but I don't like medicines for it. Very important that we keep it. So you mentioned blood pressure. What else?
High cholesterol.
High cholesterol. So it's important if somebody's had a TIA that you get their cholesterol, and if it's elevated?
Absolutely.
What do you do?
Usually we give medications to help with that. What are called statin medications are commonly used. Probably more important than medications that we didn't mention yet is diet and exercise, right? So the things that we do in our life.
Does that really help? We talk about diet and exercise, lifestyle changes. Your feeling, does that really help?
Absolutely. I do believe it helps. In fact, there are some studies that suggest a 20 to 30% reduction in stroke risk with moderate exercise after you've had a stroke, independent of other risk factors.
I think that's such an important statement. There's a 20 to 30% decreased chance if we diet and exercise. By diet, are there certain kind of diets? We talk about Mediterranean diets, DASH diets, low salt diet, but they're mainly all fruits and vegetables, decreasing especially the red meats. And they're all vegetarian diets. Are they better than just a good diet?
I don't know that they're necessarily better than a good diet. I usually advocate a Mediterranean style diet, but you know, I think you can get just as much protein and nutrition in a vegetarian style diet as you could in a Mediterranean style diet, for instance.
You know, I think people need to know that they can Google Mediterranean diet and they can get really great information on that. And if they have difficulty, see a nutritionist, a dietitian on that sort of thing. Now, what about exercise? What will that do?
Well, exercise, you know, helps with your cholesterol. It drives up that good cholesterol, that HDL. It helps with blood pressure. It helps with your diabetes if you have diabetes. And it'll help you lose weight. And we know that weight loss is important risk reduction for stroke. And there's really good evidence to suggest that exercise helps our cognition, current and later in life.
We've had some information on the Dr. Bob Show on exercises that causes neoneurogenesis, where there's new actual nerve endings that are formed and new blood vessels in the brain. It's a fascinating subject. So you are a strong advocate of eating properly and exercising frequently.
Absolutely.
Let me talk to you about sudden loss of vision in one eye. Doesn't matter the left eye or the right eye. Could that be a stroke?
Absolutely. And sudden vision loss in one eye, especially painless vision loss in one eye, can be a sign of a blocked artery to the retina of the eye. And essentially the retina is brain tissue, so I call that a stroke.
Do you treat it the same way? Do you treat it with your TPA?
Absolutely. If that person gets to the hospital in the time frame for TPA, and there is a time frame for it, if you exceed 4.5 hours, we can't use the medicine. The benefit goes away after 4.5 hours, essentially. But if that person comes in within the time window, and there's no other reason not to give it to them, absolutely.
I've seen 2 people at our church who have had sudden vision loss and they really didn't get to the doctor quickly. Have you ever seen TPA work with somebody that had sudden vision loss?
I have. I've had a couple of patients that have done quite well after TPA.
And we were talking about that earlier. I knew what your answer was going to be, but it's very important. So we can recognize sudden vision loss, one eye. We can know that there are things we can do to prevent a second stroke. We know that getting to the doctor quickly is a key to success. Anything that you would advise people that say, I'm scared to death of getting a stroke?
I think the main thing is education and making sure that your loved ones, your neighbors, your coworkers, your classmates know the signs and symptoms of stroke. You know, I think of our stroke team at the hospital it's the best team in the region. It's the best team in our hospital when it comes to treating acute stroke, or and essentially the community is an outreach of our team. And if we didn't have our community folks that know what a stroke looks like, people aren't going to get to the hospital in time. And so I think it's critically important that we educate ourselves on what a stroke looks like and what to do when someone has a stroke.
Brian Wiseman, thank you for coming to the Dr. Bob Show and teaching us that early recognition of signs of stroke is so important. Eat right, stay healthy, exercise. You're a great guest. Thank you for coming.
It's my pleasure. Thanks for having me.
You've got the information. Now it's up to you to be part of the extension of a stroke center. So if you recognize those signs in somebody, get them to the hospital quickly, but otherwise, do the things that we like: exercise, eat properly, get 7.5 hours sleep, laugh a lot, and you'll stay healthy. But now we're going to come back and talk a little bit about sudden severe GI bleeding, bleeding from the stomach, and also gouty arthritis. What causes it? What can we do about it? I want to thank Dr. Brian Wiseman. Wonderful discussion on strokes, either hemorrhagic or ischemic. And now for questions from you, the viewer, that I think will be important to your health. Question number 1, Dr. Bob, what are the causes of sudden severe GI bleeding? You know, GI bleeding, bleeding from the whole GI tract, can be in the upper GI or lower GI. It can be chronic oozing of blood, or it can be sudden and severe. The cause of sudden severe upper GI bleeding is usually either in the esophagus or in the stomach or in the duodenum. Peptic ulcers in the duodenum, gastric ulcers in the stomach, or even gastritis in the stomach, or bleeding from the esophagus. And it's sudden severe bleeding where somebody can lose half their volume of blood in a period of just 3 or 4 hours. At that time, people frequently will vomit up bright red blood or coffee ground material. They'll look pale. Their pulse is very rapid. They're short of breath. They feel weak, and they just really feel like they've lost all their color. If somebody vomits up bright red blood, then immediately you need to get them to the emergency room. In the emergency room, they'll be able to do an EGD. They'll be able to look down at the esophagus, see if the bleeding's there, go into the stomach, see if the bleeding's there, and go all the way into the duodenum to see if the bleeding's there. Once they find the site of the bleeding, there are several things that can be done. Number 1, they can inject around the area with some epinephrine, medicine that makes the blood vessels go into spasm so they stop the bleeding right there. Or there can be cautery, or there can actually be tying off of the area that's causing the bleeding. So know that severe upper GI bleeding is emergency, and you must get to the emergency room immediately. And when we think about it, when we think of the causes, we think of people that are using lots of NSAIDs, ibuprofen medications that get gastritis, and people that have peptic ulcer disease, heartburn, acid indigestion. Be aware of getting to the emergency room quickly, just like symptoms of a stroke. And question number 2, Dr. Bob, let's see here. Why does gout seem to hit the big toe? Well, gout can hit any joint. Usually it's large joints, but the big toe is called podalgia. It's a frequent site for somebody to get gouty arthritis. And that's where uric acid crystals get into the joint, and it is a very painful, swollen, hot, red joint. Enough to where if you're on the bed and somebody comes to sit down on the bed, you don't want them anywhere near that foot. Once the diagnosis is made, there is excellent treatment. Basically, long term, it would be lowering of the uric acid, which is usually elevated. That will keep people from having recurrent gout arthritis attacks. But there are some medicines for the acute attack. One would be colchicine, one would be butazolidine, one would be prednisone and steroids. All of those are very, very effective on an acute gouty arthritis attack. So if you've got a painful, hot, red joint and it recurs in different joints, think about gout. See your doctor, talk about gout. He'll get your uric acid and he'll make sure you get on the right treatment. Well, that's all the time that we have for this show. Remember, exercise is so important. It will help prevent strokes. It doesn't keep all people from getting a stroke, but it decreases the incidence. It lowers blood pressure, it lowers stress, it helps us lose weight, gets rid of sodium. It's a wonderful thing for people to do. If you want to be healthy, exercise needs to be a part of that. Get 7.5 hours sleep. The literature says that 7.5 allows the brain to rest. If you're not sleeping well, you need to think about why that is. Is there pain? Is it medication? Is there too much noise in the room? Are you not preparing to go to sleep well? If you're not sleeping well, you may need to see your doctor. And eating properly with fruits and vegetables. Google that Mediterranean diet or DASH, D-A-S-H diet. They're basically the same thing. The DASH is more low sodium. And most of all, what is it that we like on that Dr. Bob Show? It's that giggling and that's laughter in your life. The more you laugh, the more people around you will be happy and healthier, and you also will be healthier.